Hi, this is Lisa Costa-Beer. Join us on FX Medicine next week, where I'll be talking to naturopath Sandra Villela on naturopathic management of premenstrual dysphoric disorder. Subscribe to us on your favourite podcast app and follow us on social media to make sure you never miss an episode.
Hi, and welcome to FX Medicine, where we bring you the latest in evidence-based integrative, functional and complementary medicine. FX Medicine acknowledges the traditional custodians of country throughout Australia where we live and work, and their connections to land, sea and community. We pay our respect to their elders past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. With us today is Dr Miranda Myles, an integrative naturopath, clinical nutritionist and acupuncturist. She is a thought leader in women's health, hormones and fertility. With over 20 years' experience, Miranda has successfully worked with more than 20,000 patients in natural gynecology and reproductive medicine, IVF support and male factor infertility. She is director of Freya Health, one of Melbourne's leading natural health and fertility clinics. She is founder of the Thyroid Institute of Australia, host of her podcast The Donor Project, an author, and she has several new books on the way. Academically, Miranda is a highly respected lecturer in nutritional biochemistry and nutritional medicine, as well as a speaker and mentor. Her mantra is test, don't guess. Today, we are going to deep dive into iodine to learn the when, the how, and the why of prescribing guidelines. And we will bust some myths surrounding iodine along the way. I know that I am going to learn a lot, as I find this area can be really tricky in clinical practice. Welcome to FX Medicine, Miranda. Thank you so much for being with us today.
It is an absolute pleasure, Emma. I love doing this. It's just so important.
It is really,
sharing knowledge,
It is super important, I agree. Now, let's just set the scene for a minute. In the late 90s, national survey data showed Tasmanians had the lowest levels of iodine at an average of 108 microgram per litre, and this drove Tasmania to introduce the iodine fortification program in 2001. And then in 2003, the National Iodine Nutrition Study measured the iodine status of Australian school children, and the results showed that kids were mildly iodine deficient. In the 2011 national data set, women of childbearing age showed the highest level of deficiency, with 18% of women having lower than 50 microgram per litre levels and a huge 62% having levels below 150 microgram per litre, which is the iodine level recommended by the World Health Organization for pregnant and breastfeeding women. Now, clinically, iodine, it is an absolute minefield. And today, my goal is for us all, including myself, to walk away feeling like we have a clearer picture of the how and the when to use iodine. And, Miranda, I want us to challenge our current thinking with how we view iodine and how we use it clinically.
I'm pretty sure we're going to do that, Emma.
Well, in researching for this episode, I feel like my brain is a big pile of spaghetti, I have to say.
Yeah, I think a lot has changed, and our thoughts do actually need to be challenged a little bit with iodine and just some of the more current thoughts around it.
Really looking forward to getting into this with you. But let's just start with the basics. Can you explain what iodine is and what its role is in the body?
Okay, well, most of us know that quite simply iodine is used as the main mineral to make our thyroid hormones. It actually starts off its life as iodide, though, in the blood, and the iodide is transported to the thyroid lumen and it gets converted to iodine by an enzyme called thyroid peroxidase enzyme, and that's an iron-dependent enzyme. So we need, the very, very first thing we need is iron to make sure iodine is being made so that it can actually be attached to tyrosine.
Mm-hmm.
Yeah, so then what happens is one or two iodine molecules attached to a tyrosine molecule in the thyroglobulin chain.
Mm-hmm.
That makes T1 and T2, which then couple together to make T3 and T4, and then T3 and T4 are shunted out into the bloodstream.
Okay.
I think the really important thing with this, just straight off the bat, is that there's actually no circulating level of iodine in our blood, though.
Okay.
Iodide is how we find it, right? And the iodine is actually quite corrosive and can cause blistering or skin necrosis, which is like a chemical burn.
Mm.
The actual only place where we find iodine in the human body is within the follicles of the thyroid gland. And even here, it can be a bit of a liability if there's too much. So it's just one of those things. Iodine, iodide, it's iodide in the blood, and it gets iodized to iodine in the thyroid gland.
Because I think we use those words interchangeably, really,
interchangeably
don't we?
a lot, yeah. And there's also iodate as well, but basically iodide, iodine, iodate, they all ultimately wind up as iodide in the blood, and then iodine in the thyroid.
Right. Okay. And what about the halogen story with iodine?
Okay, so there's the other halogens, the chlorine, which we find in water, fluoride, which we also find in water and toothpaste, bromine in bread, and then iodine in bread and salt. And I've taught nutritional biochemistry for a very, very, very long time, and one of the things I've always taught is that those other halogens in the periodic table, they're all in the same line together, and they all displace or compete with each other, so they displace iodine. But very recently, I read some information to suggest that there's perhaps a little bit of conjecture over this now.
Okay.
What I read was that fluoride does compete with iodine, and they share a transporter called the sodium iodide transporter. So basically, fluoride gets on that transporter and takes up the room on that transporter and kind of bumps iodine off, right? So fluoride and iodine most definitely do seem to be competing. But now there's some questions over whether the amount of chloride that we actually ingest or that we're exposed to, is it enough to actually displace iodine? And I can't answer that. I don't know anymore.
Yeah.
That's probably why your brain feels like spaghetti, because it's things like this. It's like, well, this is what we've always thought.
Yeah.
But now, is that actually correct? And then this research also showed that there was a study that looked at bromine, and it was dosing more than 300 times the level that would normally be consumed, and there were no changes found for TSH or T4 or thyroid binding globulin, which you would expect there to be changes if it was affecting iodine.
You would.
So it's like, okay, well, I don't know anymore.
Yeah. So we can accurately say that fluoride will displace, but there's questions around the chloride and the bromide.
Yes.
Okay. More research needed, right?
Yeah, absolutely.
And
absolutely.
What are the factors that drive low iodine levels that you see?
Okay, so there's topsoil depletion. There's we're not replacing that topsoil. There used to be the use of iodophor, which is like a disinfectant used in both the dairy and the brewing industry, but that's actually not being used anymore. So we've lost that sort of indirect source.
Okay.
It's not being used as a fertilizer anymore in commercial agriculture. We have, we've always talked about environmental goitrogens as well, that environmental goitrogens blocks the uptake of iodine. And I think about that a lot, and it's like, yeah, but is that enough to be clinically relevant? Because, where we find those goitrogens in some of our leafy green vegetables, which are just so incredibly important for health generally. Is it are they really a major problem, or are they like just a bit of a 1%er? Because as we know, you cook the vegetables and there's no problem, right?
That's true.
The goitrogens aren't an issue anymore. So I do think about that a lot, comparing it to something like the phthalates or the parabens or the phenols or the BPAs, which are so much stronger than any sort of vegetable-based thiocyanates or goitrogens. So I kind of question that a little bit sometimes.
Yeah, and I think it's also about weighing up the pros and cons. I mean, when you're looking at broccoli and all these beautiful vegetables, are they a problem? Probably not.
Exactly. In the bigger picture comparative to everything else. It's sort of that sort of interesting thing. And then, of course, as we know, Australia introduced the iodization of bread in 2009, and we did see a modest increase in the median urinary iodine concentration with that, particularly in pregnant women. And that public health initiative of iodine fortification in bread was based on people eating 3 slices of commercial non-organic bread a day. So when you look at that, all right, what level of the population is eating 3 slices of commercial non-organic bread a day? Most of the population would be eating that. So I think our patients don't act because we'd be putting them on organic bread, if anything. But for those people who, the rest of the population eating 3 slices of commercial bread a day, plus, some sacks of table salt, which has also been iodized, many people would be actually getting more iodine than, say, our population group, our patients.
And that's an interesting concept right there, is looking at the patterns and trends of our patient demographic and looking at those factors. But is there a patient demographic that's a particular risk of having low iodine levels? Which patients should we keep in mind for this?
So, I mean, women are at higher risk than men of being iodine deficient.
Okay.
And whether I would suggest that's probably hormonally driven, the connection between thyroid, ovaries and adrenals. So we do know that. Then pregnant women, obviously with higher fetal needs. So in the first trimester of pregnancy, the fetus relies solely on the mother's thyroid hormones for their own thyroid development and iodine supply, right? And then they start to sort of take over and produce their own thyroid gland. So definitely in that first trimester, we can see risks there, and then also again in the third trimester.
Okay, interesting.
Which again is when there's massive amounts of growth that's sort of going on. And also for breast tissue development, then obviously for breastfeeding and keeping on moving forward with needing that iodine supply during pregnancy.
Okay.
And then, I was just going to say, we've got people who are, the people who are hypothyroid. They are at risk of low iodine levels, whether the low iodine is causing the hypothyroidism, which might be something else. If we do eat organically and if we avoid iodized salt, we might be at risk.
Okay.
Yeah, but then lots of people eat sushi too.
That's true. That's true.
And then lean women, thinner women generally tend to have lower levels of iodine than obese or women with a higher BMI.
So that's a key insight. I love that one. That's just putting someone on our radar, looking at the literature there. That's great. But
particularly because we tend to think about lean women as being healthier and it's not always the case though, is it?
No, that's absolutely right. But conversely, are there patient demographics who might be at risk of already having high iodine levels?
Okay, so yes, there is, and I think this is really interesting. So there are particular medications that can increase iodine levels, and one of the big ones is amiodarone, which around 200 milligram tablet of amiodarone contains about 75 milligrams of iodine.
Oh my gosh, that's so much.
Yeah, which is really high.
Yeah.
And amiodarone is a blood pressure medication. So it's like, oh wow, okay, that's right up there. And then in the fertility world and the IVF world, women are often getting lipiodal flushes.
Okay.
And lipiodal is an iodized poppy seed oil that's being injected into the uterus and into the fallopian tubes to flush the tubes. So it's like hysterosalpingo contrast.
Okay.
Right? It's the fluid that's being put in is now an iodized poppy seed oil to check tube patency and fertility, and one 10 ml ampule contains around 4,800 milligrams of iodine.
Okay.
And the total dose that should be administered should not exceed 20 mils. So that's up to 2 ampules, and that goes up to 9,600 milligrams of iodine.
My goodness. So do you think that those effects are transient, or could they be problematic?
Well, I mean, you would hope that they're transient, wouldn't you? That basically if you stop once they've done the lipid oil flush, then we're hoping that if they have a sensitivity or a susceptibility to effects with iodine, we would be hoping that they would then just normalize again. But who knows? Maybe it triggers off a whole new set of events.
Yeah, exactly. That's right.
And that's the thing that we don't really know. I mean, lipid oil flushes have not been around for a long time, well, not commonly used for a long time. And I know some of the IVF specialists are quite, they are quite aware of the potential increase in the iodine and thus the potential effects to T4 and the thyroid.
Interesting. So, we're talking about medications like amiodarone. We've got the flush used for IVF, preconception purposes. Betadine, the topical, the surgical antiseptics. And it also makes me think, and I know we're going to get to testing, but the timing of testing with patients that have had exposure to iodine in these ways would be critical.
But I don't think that we necessarily clinically even think about some of this. We wouldn't sit there and say, did you fall over yesterday and put betadine on your knee, before they're going in for a urine analysis of iodine.
Exactly. That's right.
So I think some of these things may be missed.
Yeah, all the time. And I would put my hand up for that because it's not something that's on my radar to that detail.
No.
But I think we're learning here how to be better practitioners.
And not forgetting, your other contrast dyes that are used in X-rays and CT scans. I think some of those contrast dyes can contain around 37 grams of total iodine.
Yeah.
And that's high. These are high levels.
Yeah.
Particularly when iodine is in microgram doses. We're talking milligrams and grams.
Yes. Yes, exactly. And don't forget that 2010 bonsai dilemma. You've been in practice long enough, like I have, to remember that.
Yes. Absolutely.
Yeah. So for those of you that are not aware, the soy milk brand Bonsai was formulating their soy milk with a kombu seaweed extract. And unfortunately, that resulted in really high levels of iodine in a particular batch. And I definitely had one patient who went hyperthyroid due to her intake of Bonsai. That has been reformulated. This is, please, I'm not giving Bonsai a bad name now. No. It's been reformulated, but there was actually a class action off the back of that. So, the food really does make a difference as well.
It does. And what I think I said to you, one of my patients was part of that as well. And he was a male footballer, Australian rules footballer. So he was a machine, this man. Like, his bloods were the epitome of perfection. But it almost ended his football career because he went into a hyper state as well, so a thyrotoxicosis, and then crashed into a hypo state. Yeah. And was really unwell. If I remember correctly, he was really unwell for about 12 months. And simply because he was so finely tuned. Yeah. When something like this happens, because they're all looked after by the best of the best doctors, and he's so finely tuned, when this happened, it was just such a big deal for his system. It's really interesting.
I mean, what are the symptoms of iodine deficiency that you see in clinic? What would kind of be your sort of top 5 symptoms that we need to keep in mind?
Okay, so we always think, the typical sluggish thyroid picture. We sort of go to it might be iodine, the unexplained weight gain and the cold sensitivity and the hair loss and all of those really typical symptoms. But if there's any presence of cysts, PCOS or fibrocystic breast disease, that is a really definitive sign of an iodine deficiency. right?
Mm-hmm.
Then we also have things like, a dry mouth, dry eyes, dry skin, poor sweating, reduced alertness, scar tissues, any sort of scar tissue, fibrosis, obviously low T4 clinically if we're looking at bloods, and then a swollen thyroid because, of course, the thyroid gland expands to try to pick up as much iodine as it can when the iodine is low. Yeah, so that's where you can get that swollen thyroid or a goiter going on.
And what are some clinical white flags for iodine insufficiency that we can keep in mind? Could you give us a couple there?
So things where we would go, all right, so if that's happening, then we would be flagged to iodine sufficiency. So particularly a low end of T4, I'm sort of thinking about iodine or an iodine deficiency when T4 gets below 14.
Yeah.
I know some people sort of pick it up at below 12, but I'm already starting to think about it if it's lower than 14. And that's simply because in a Western society where we have iodized salt and we have iodine in bread and most of the population is eating those things, again, our patient demographic possibly isn't, but the general population is. So as a new patient to come and see me and they've got sort of low T4, I'm thinking, it shouldn't be the case. Like it really shouldn't be the case. The flip side of that, of course, is that some patients may not have T4 being tested.
Yeah.
So I'm looking for that increase in TSH as well. Remembering that if TSH is going up, then T4 or T3 are going down, and that's a white flag for me as well, seeing that. Because like TSH going up means something is happening at the clinical or subclinical level with your T3 and T4. So that's definitely a flag for me. Basal body temperature, if I see it, particularly in the luteal phase, if I see it below 36.3, again, I know lots of people pick it up at 36.1, but I'm sort of already thinking about it if your basal body temperature is dropping below 36.3 consistently in the luteal phase. Basal body temperature in the luteal phase should really be up around 36.6 and higher.
They are fantastic white flags for low iodine and keeping our eye out for a T4 that's under a T4 under 14, seeing an increase in the TSH, and then that basal body temperature under 36.3 consistently in the luteal phase. I feel like there's some really good things for us to hook into on that side of things. I want to, if you're willing, delve into testing because, Miranda, it is such a minefield. We have had many years of clinical practice. We have seen the patch test, the spot urine versus the 24-hour debate to the iodine loading test. But what I want to know from you as an experienced clinician is, can you talk us through what tests you use and any caveats for ensuring the most accurate results? And then can you explain what is corrected iodine?
Yeah. So the iodine spot versus the 24-hour, let's look at that first. The 24-hour is preferable, but practically it's quite tricky to be, checking every urine sample over a 24-hour period. Urine is reflective of iodine intake over the previous 48 hours, and the understanding is that approximately 90% of iodine is excreted in the urine.
Okay.
Right? Then they did look at the iodine loading test, where the patient has that massive dose of iodine, and then it's sort of tested. The iodine is tested the urine is collected for the next 24 hours, and the patient is considered iodine deficient if less than 90% of the administered dose is excreted.
Okay.
Right? So that was the whole iodine loading or the whole challenge test. But urinary iodine levels can take weeks or months to reflect changes in the iodine. And some of the research I looked at was it's usually at that 30-hour point that we get the biggest dump of iodine excretion in the urine. So you've missed it. If you're only testing up to 24 hours, you've missed it with the iodine challenge, right?
Yeah.
So then the most important thing is that when we're getting a urinary iodine done, that it is corrected. And that means that the iodine that's measured in micrograms is divided by creatinine in millimoles, and that's to account for any dehydration, and then multiplied by 8.85.
Okay.
That is the corrected iodine in micrograms that we actually need.
Okay.
Right? A lot of the labs don't actually do that. Some do, some don't. Right?
Okay.
The bit that they generally do the iodine divided by creatinine, but it's whether they then multiply it by 8.85.
Right.
And that gives the most accurate testing that we have. No tests are actually 100% accurate. We know that with everything, but this gives the most accurate. So it's really important. I believe Lavity in New South Wales does. They do this corrected dose properly. I believe some of the other labs don't, and Lavity is associated with Dorovich, so that's in Victoria. So I tried to actually ring Dorovich this morning to just double check, because it got me thinking about it all again, of course.
Yeah.
But I didn't get through. So, but I do believe they're affiliated. So I would suggest Dorovich is right as well. But it's incumbent on us as practitioners to make sure that corrected iodine is being measured, and B, ring the lab.
Yes,
double
agreed.
check,
And yeah, in my experience, the pathologists at labs are more than happy to talk to us. When we really ask those technical questions, they really, I haven't had a bad experience.
But they love it. Yeah. It's their opportunity to shine a little bit, isn't it?
Yeah, exactly. And with that urine testing for iodine, when do you do it? Are there any, caveats around when they should do it? What do you tell your patients?
Okay. Can I circle back to that one in just a second?
Yeah.
There was one other thing I just wanted to say about the creatinine also, is that we want to be measuring the patient's own creatinine levels, because some of the labs, what they also do is they use a median creatinine instead of the patient's own actual creatinine value.
That's just
which is nuts.
irrelevant.
That's crazy. Why would we be using the median measure of somebody else, some other random group of people, rather than our own?
Yeah.
So again, it's making sure we have the iodine divided by the patient's own creatinine level, and then multiply that by 8.85.
Okay, really good insight.
So there's a couple of things to check there. Yeah. Sorry, I cut you off.
The caveats around the urine iodine test. When do they do it? How do they do it? What do you tell your patients? What instructions do you give them?
So when I do it, we will do a fasting morning, the first morning void. And the questions around, do we need to avoid particular high iodine foods? I don't tell my patients to do that, simply because I want to know what's going on in their normal, right, in their normal life. Hydration status is really important though, and then, as we talked about, that measurement for creatinine to account for any hydration issues as well. So sometimes the readings can come out a little bit odd, so hydration is actually really important when we're looking at these measurements.
Yeah, and I find clinically that I'm usually asking patients to do this test privately, because it's unfortunately it's just something that Medicare is not going to cover quite rightly unless certain conditions are met. So it does tend to be a private test, which I think is around $46 here in New South Wales. Not sure about for you.
I think it's about the same here. I think it's $59 here, something like that. But yes, it's not going to break the budget for most people, and that's where it is one that can give us so much valuable or important information, particularly around thyroid and some of the other things we'll get into as well.
Exactly, that's right. And before we dive into dosage and forms, I want to just quickly touch on the RDIs, because the recommended daily iodine intake is 150 micrograms in adults who are not pregnant or lactating, while all pregnant women should consume approximately 250 micrograms of iodine per day. What do you think of those as a guide?
So what I find really interesting in pregnancy is the 250 micrograms daily. And this is something that's become very obvious to me just since we've been talking a lot about this, Emma, is that we know that pregnancy is your thyroid's greatest stress test.
Yeah.
We also know that in pregnancy, thyroid antibodies can do all sorts of wonderful, amazing things. Or if a pregnant woman has not had her thyroid antibodies checked pre-pregnancy and does have pre-existing and existing thyroid antibodies during pregnancy, how do we feel about a dose of 250 micrograms of iodine or up to 270 micrograms of iodine in our prenatals? Because as we know, iodine makes thyroid antibodies more aggressive. And yet in pregnancy, the fetus, as we talked about earlier, particularly in the first trimester and the third trimester, needs that iodine supply for brain development, particularly in the first trimester. It's like, okay, so where do we sit with that? Because if you've got a pregnant woman on 270 micrograms of iodine plus dietary sources, there's a lot of iodine in seafood. And so we talk a lot about salmon for our patients. And so we can get this high exposure of iodine from diet, as well as then another 270 odd micrograms in pregnancy. So it's making me really question, the supplementation levels now.
Good point.
Yeah, because we don't say to a pregnant woman, all right, well, I'm going to put you on a low iodine diet, because that means taking out a lot of really important foods that have other benefits in pregnancy.
Exactly. That's right.
So, 150 micrograms of iodine is required for adequate thyroid hormone synthesis. That's a day.
Okay.
The median levels range between 100 to 199.
Okay.
And then some of the research we were sort of looking at 200 to 300 micrograms there is a risk of iodine-induced hypothyroidism in susceptible groups.
Okay.
And then over 300 it increases that risk.
Okay.
So it's really interesting, the pregnancy thing, I think, don't you?
Yeah, I do, because we all, just as a generic recommendation, provide our preconception and pregnancy patients with really complete preconception and pregnancy supplements, but all of them have around the 270 micrograms. And what is the effect, the cumulative effect here of that plus dietary source if a woman has thyroid positive antibodies? What risks are we actually exposing her to?
So, I mean, the biggest risk is then obviously the antibodies can go up.
Yeah.
They can increase. And I was talking to a patient of mine recently. She had thyroid antibodies and she was on iodine and quite a normal dose of it, 270 micrograms of iodine. And in fact, no, she was actually on higher than that. She was on higher dose of iodine, including, dietary sources. And it did wind up that her baby had thyroid antibodies at birth.
Fascinating.
So, it's really, I don't know how common that is, but that was certainly something that I was faced with this woman. But also it's not even so much about what happens in pregnancy, but that postpartum period.
Yeah.
If you have driven those antibodies up really, really high, we're then, of course, at risk of a thyrotoxicosis or a postpartum thyroiditis, where we wind up with a hyperthyroidism at around the 3 to 6 month point postpartum, and then a big crash into hypothyroidism somewhere around that 6 to 9 month point. So it's not just actually what even is happening in pregnancy, but the after effects as well.
Yeah, and look, I can immediately think of at least 5 patients that I have seen in the last 6 months with postpartum thyroid issues, all presenting at around that 6-month mark. And I think, if we dial back and look at the iodine story, it may not be the only thing going on, but I think we really need to challenge our thinking here. But I want to implode all our brains a little bit more on this iodine side of things. I want to think about this study I read. So it was a 2023 study. It was on 2,934 men aged between 18 and 65, average age of 47. And they looked at levels of urinary iodine and testosterone. Interestingly, they found lower iodine levels were associated with higher testosterone levels independent of factors that may influence androgen status, like age and features of metabolic syndrome. And the researchers postulated that high iodine could accumulate in the testes, driving up oxidative stress that causes lower testosterone synthesis. And they cautioned around excessive iodine supplementation. But this paper really got me thinking about the impact of too much iodine on a cellular level.
Absolutely.
What are your thoughts here?
Yeah, so I found this fascinating as well. So, and this was it's fairly new research as well, and it's such a, when we talk about iodine, it's like this U shape, isn't it, in relation to intake and the risk of thyroid disease. So, if you've got too lower iodine, it's problematic, but if you have too much iodine, it's problematic. So it's that real finding the balance, finding the Goldilocks, finding where we need it to be sitting. So we know that both iodine deficiency and excess are associated with poorer seminal quality and longer time to pregnancy, right? We know that. This leads me to go, all right, so if we have too much iodine that's affecting testosterone levels, is this not another reason as to why we need to test males when we're going down the fertility pathway? I mean, everyone tests the poor old females, the men never get looked at. And if you've got these issues happening with too much iodine, then suppressing testosterone levels, obviously that's going to cause fertility issues.
Yeah.
Right? So for me, it's another argument of going, well, we need to be checking iodine status in men and testosterone status in men in that preconception period.
Exactly.
We just don't. It's just, again, another one of those times where men are overlooked, and it becomes really, really imperative as clinicians to be doing that.
And explaining that research to men, to your patients. We will put the link in the show notes, but really giving that evidence-based approach of why we want to test for iodine and testosterone in these patients, but not just male fertility. I am thinking, about a guy who saw me last week who is exercising, eating well, but his body composition isn't changing, and we're testing it. And I'm now thinking, well, we probably need to look at his iodine and his testosterone because so we can really be so refined with this awareness around iodine now.
Yes.
Yeah, it's fascinating. And I was giggling before because the whole we're not testing the men in this story, we're testing the woman and we're sending her for all these tests. It's like, okay, all right, it is another reason, a well-validated reason to be testing men for iodine and testosterone.
Yeah, very much so. And that research did, and they did quote some studies with rats where they were looking at this, after a high iodine diet feeding, the iodine accumulates in the testes and triggers oxidative stress that inhibits the 3-beta and 17-beta hydroxysteroid dehydrogenase activity. So that's the enzyme that's actually, or the enzymes that are actually being affected, lowering testosterone levels. Now that bit was in rats, but it still carries a lot of implications for what we need to be looking at in men.
Yeah.
It also, though, makes me think about women's testosterone levels. We need to stop thinking about testosterone as only being a male hormone. Now, obviously, this is saying it was happening at the testicular level. It's like, okay, well, is it going to be happening in women on another level as well? Don't know.
Yeah, this is where there's gaps in the research, isn't there?
Yeah. There's gaps here. So, yeah.
Now,
just a fascinating thing to think about.
That's why my brain's like spaghetti. Now, we've covered so much valuable information. I wanted to move on a little bit to the forms of iodine, but I wanted to share a quick patient story with you about iodine dosing, which is what we're going to discuss. A patient came in last week and she'd self-prescribed iodine as she heard it was really good for her hair. She was postpartum mum, about 12 months postpartum, and her hair had been falling out. So she bought some Lugol's iodine online and she was taking 3 drops every morning in a little bit of water, and she took it for 3 weeks. I know you're laughing, but wait till you get to the so she took it for 3 weeks, and then she called saying, I need to see you urgently. She presented with palpitations, fainting, low blood pressure. And when she told me what she'd been doing, she was taking the equivalent of around 18 milligrams of iodine a day. And she was
scary.
Perplexed. She was like, Emma, it's only 3 little drops a day. Anyway, I told her immediately stop it, actually throw it out, go straight to your GP for a thyroid assessment, including thyroid antibodies, which I'm pretty sure she's going to come up for positive now.
Yeah.
But, the form and the dose of iodine, I mean, I'm surprised she didn't end up in hospital, but we have to really know our stuff in this space. So talk us through it.
So, well, 1 drop of Lugol's iodine is, 6.5 milligrams. So that's massive when we're talking microgram doses.
Yeah.
It's an incredible amount to be taking, and I would be very cautious around Lugol's nowadays. 20 years ago, I probably would have dosed a drop for some people if I felt it was necessary, but I wouldn't do it now.
No.
It's just, there's too much information now. And there's lots of claims also around, the different forms of iodine that we need to have. Basically in our supplements, it's potassium iodide. And as I said earlier, pretty much no matter what form you take it in, it all gets converted to iodide. Some people say, the best forms for the breasts, prostate and female repro are iodine, and the thyroid form is iodide. It's like, well, it doesn't really matter. Everything, your gut converts all of it to iodide, and then the iodine is found in the thyroid. Yeah, so it sort of doesn't really matter from food or supplements what you get. There is that conversion, but steer clear of Lugol's.
Yeah, absolutely.
Oh, that poor woman.
I know.
Oh my goodness.
I know. It's quite scary.
And of course, as you said, the chances are she'll now come up with thyroid antibodies.
Yeah. Yeah, I'd be highly surprised if she didn't.
Highly surprised if she didn't. Yeah.
So this complex area of how to dose iodine safely and correctly, can you talk us through it? Because I know there are some caveats around autoimmune situation with iodine, and I just want to know, what patient demographics do you not prescribe it for, or it's contraindicated? Tell us a bit about what you do.
So remember the Wolff-Chaikoff effect?
Can you explain it for us? Yeah.
Yeah. So we've got what researchers have been sort of finding, or even since 1940, they've been looking at this, that a high dose of iodine can stop thyroid function, right? So our thyroid basically has a safety switch. With too much iodine, rather than making excessive and potentially lethal amounts of thyroid hormones, your thyroid switches off. So it's basically, this is homeostasis at its finest. Yeah. And this is, again, where we've got, the U curve. If you've got low iodine, then we have issues with thyroid hormones. But if you've got too much iodine, we also have issues with thyroid hormones. So a high iodine intake causes rapid reduction in the synthesis of thyroid hormones.
Okay.
And that can trigger the autoimmune thyroid disease, which is exactly what we're saying with your patient. Yeah. It's not an all or nothing. Low iodine slows thyroid hormone production, but too much iodine speeds it up and then shuts it down as well.
Okay.
Right? So low or high iodine can slow down thyroid hormone production. How do we know it's real? Well, we've got the Graves hypothyroid storm. Acute treatment of Graves in hospital is high dose iodine.
Fascinating.
Right? Yeah. And then there can be congenital hypothyroidism after maternal exposure to excessive iodine, which is one of the things I sort of touched on before. Babies have been born with toxic iodine levels due to the high levels that their mums were taking, and then the baby's thyroids are being shut off.
Okay.
So we have to be really, 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 really careful with that, you know. As I was talking about before, excess iodine inhibits thyroid hormone synthesis and can increase that TSH. So TSH elevation is not a good sign. And it does mean you're getting hypothyroidism, and so you need to kind of be careful.
So on that, can I just press pause for 1 second? Because I know, I want to know, everyone else wants to know, what is the number of TSH that you see as starting to become an issue?
Okay, so I love the TSH. Again, it's lab specific depending on the labs, but in general terms, I love the TSH to be sitting between 0.5 and 1.5. 2, I can cope with it being at 2. That can be just, you know, diurnal changes and daily changes. But once it's starting to go 2.5 and above, it's not even just absolute number, but it's whether we've got a history of it being high. You know, I had a patient the other day and it was 2.5, and then it was 3.1, and then it was 2.8, and then it was 3.5, and so it was this up and down, but the general direction that it was going in was the TSH was going up ultimately.
And I guess it's looking at trends with the T4, with the basal body temps, with the signs and symptoms. It's that cluster we're looking for, that trend and that pattern, rather than just that one number is important.
Yeah, and we never take one blood test to be the be all and end all. We need to see a history and know what was going on at those particular times. You know, was there something specific or something different that happened at that point in time? You've got to ask questions around that, not just take the numbers at face value. I think is really, really important as a clinician to be going, okay, well, you know, did your TSH, because if you look at somebody's bloods and you see the TSH jumping all over the place, it's like, well, why did it go down there? Why did it go up there? Was there something really significantly different that happened at that point in time? Like, you know, they started taking thyroxine.
Yeah.
You know?
Yeah.
Or they started, you know, taking some iodine.
Yes. But who don't you prescribe iodine for? Like, what group of patients do you never use iodine?
Yeah, so I would never, ever be giving iodine in Graves, high thyroid antibodies, a multinodular goiter, thyroid cancer, fetal congenital hypothyroidism, as I was talking about before, or any sort of autoimmune thyroid disease. I would be very, very careful, because high iodine exposure is known to cause those things. Hypothyroidism, hyperthyroidism, goiter, autoimmune thyroid disease, nodules, thyroid cancer, and fetal congenital hypothyroidism if you're suspecting something going on there.
Okay. All right. Now, to round out this conversation, last question for us. Let's hit the fun area of prescribing guidelines. Do you do a loading dose? At what point do you retest iodine? You know, what are your clinical guardrails around prescribing?
Okay, so if there is low T4, and again, I'm sort of saying less than 14. Again, some people say less than 12, and there's no antibodies, right? And I'm quite comfortable there's no antibodies, then yes, I will prescribe.
Okay.
If there's a low T4 to T3 ratio, again, no antibodies, yes, I will prescribe.
Okay.
I don't do a loading dose. I will do I might start as low as 75 micrograms, sometimes 100. It depends. Sort of depends what I'm doing. So, I wouldn't go a big loading dose at all. No, I'm much more conservative than that. And that's probably more now as well, Emma, sort of looking at this in a little bit more critically and going, okay, well, we do actually need to be careful, because we might not know if someone is susceptible.
Correct.
You know, particularly when we first see them, we might have no idea whether they're susceptible or not. So I would go more gently than high dose. If there are thyroid antibodies, then I'm always trying to get those thyroid antibodies down first.
Yeah.
Selenium, myoinositol, Nigella, whatever we need to be doing, going off gluten, going off dairy.
Yep.
You know, even in those situations when there's thyroid antibodies, I might start thinking about a low iodine diet.
Yes.
But I'd be just going, let's not take out all the good food, you know, because you still need some level of iodine for basic function, but sort of trying to get it at that, around that sort of 150 micrograms a day rather than, you know, big, massive doses. So again, in antibodies, I'd be going, try to get the antibodies down first.
Okay.
And then look at maybe drop dosing iodine and seeing if that then increases the antibodies. I would be testing 6 weekly.
Okay.
You know, monthly, 6 weekly. Yeah, and again, of course, it depends on finances, doesn't it? Because we can't just say to them, can you please just go around to your GP and get your antibodies tested, because they don't do it. So it comes down to, all right, we've got to balance it against the out-of-pocket costs as well. So, but generally speaking, I like to sort of go six weekly. And then in pregnancy, I really want women to be being tested at least every trimester.
Okay.
Absolutely testing before they conceive. If you catch them before they conceive, if you've caught them in the preconception period, at least test antibodies. And then, you know, if there's an issue there, I'd be looking at iodine.
Yeah. Okay.
Yeah.
Makes sense.
Does that make sense?
Yeah. I think there's some really good, clear caveats around there. And look, I think this conversation is a bit like an iceberg, and our learning is a bit like an iceberg. In researching for this, I realised how little I do know about iodine when I thought I knew more. But there is a lot we don't yet know. There's still a lot of research where there's gaps, and we're going to have to wait for that research. But, you know, I've really enjoyed diving into this with you, Miranda, and your insights and clinical pearls in this space.
It's an absolute pleasure, Emma. I think it's really important that we do say iodine is neither good nor bad.
Good point.
Because I don't like it when we put nutrients out, or when we get really scared of a nutrient. We need some, right?
Yes.
But too much is, or can be, or it is, you know, too much is harmful. And it does make me question whether, do we still have an iodine deficiency on planet Earth?
Yeah.
Like,
yeah.
Is it a thing? Is it a thing in a Western society? I just don't know anymore.
And look, the research I looked at, you know, it's historical and I understand it, but with all of the public health things that have changed, I don't think we are as low iodine as we once were. I tend to agree. And, you know, that's, again, looking at that research from the 40s, 50s, 60s, yeah, they probably were. But now, you know, we get some pretty good public health initiatives that happen. Exactly, that's right. Well, thank you so much for joining us today, Miranda. I have taken away many clinical pearls. A couple of my top favourites are white flags for low iodine, include a T4 under 14, an increase in TSH above 1.5 to 2 as a trend, and a basal body temperature under 36.3 in the luteal phase, and how critical it is to find that Goldilocks zone with iodine, and knowing that we do prescribe it in certain conditions that you've outlined, and then don't prescribe it for other conditions. That gives us a really clear picture. So thank you.
It's an absolute pleasure.
Thank you everyone for listening today. Don't forget that you can find all the show notes, transcripts and other resources from today's episode on the FX Medicine website. I'm Emma Sutherland, and thank you so much for joining us today. We'll see you next time. This podcast is intended as healthcare practitioner education only, and it is not a substitute for medical advice, diagnosis, or treatment. If you enjoyed this episode, please take a moment to give us a rating and review on Apple Podcasts, Spotify, or wherever you listen to FX Medicine, and share us with your family, friends, and colleagues.